Evening. Welcome to Ask Me Anything with Dr. Twyman. I'm a board-certified cardiologist. I help people avoid heart attacks and strokes. I started Apollo Cardiology back in 2019 to focus on proactive preventative cardiology. Used to be an invasive cardiologist, taking care of people very sick, potentially dying. Thought there was a better way, so decided to launch this practice. Been on Instagram since 2019 and been doing these Ask Me Anything since that time to help people understand their true risk factors for vascular disease. If people are interested in learning even more, I do have patients from 48 of the 50 states currently who come to work with us at Apollo Cardiology here in St. Louis, Missouri. My website, drtwyman.com, has the application if you're interested. Another way people learn is we have a school community, drtwyman.com, school, I should say. I do longer Ask Me Anythings there, and it was recently decided that people were interested in doing case studies. So people who are okay with sharing their biomarkers, genetics, and imaging will do some kind of reports where I'll go through it, interpret it the way I would do it if they were sitting with me live one-on-one at Apollo, and talk about what I'm thinking about, what you need to do to optimize your lifestyle. If you're on certain nutrients or supplements, which ones to potentially utilize, and pharmacological interventions based off your genetics and your desires, plus what is really going on with the lining of your arteries. So every Monday in the morning in my stories, I put up a question box. Those are the questions that get answered first in this format here. If you're joining now live and want to drop a question in the comments, I'll try to answer those as well. So with the housekeeping out of the way, I'll jump into the questions here. First question tonight, considering a therapeutic ketosis for health reasons, what are my thoughts regarding for heart health? So ketosis is a strategy. It's something that depends on what is the underlying health reason. If you have a seizure disorder, if you have a malignancy, there may be some very strong reasons to be doing ketosis long-term. Evolutionarily, you would have had it be present if you're in a place where the ground freezes and vegetables don't grow in your environment. You would have eaten animal-based, and you would have been ketotic by nature's rules. Now, there are reasons to do it, but from a heart standpoint, we'd have to look at what happens to your lipoproteins after going on a higher fat diet. Some people it has no effect. Some people their lipids get significantly abnormal. Doesn't always mean they're going to develop plaque in the arteries. You also have to look at pathways of nitric oxide and inflammation. Next question tonight, do I recommend doing both type 2 and HIIT cardio? The answer is yes. You're doing different fuel partitioning with that. So zone 2 is more about fat metabolism. HIIT's more about carbohydrate. HIIT, you have obviously compressed time frame of doing the activity. Zone 2 is generally going to be 30 to 45 minutes. But it really depends on what are your goals, how fit are you to begin with. But if you're more fit, generally about 80% of your cardio should be in that kind of low, slow zone 2, and approximately 20% of it would be the interval training. But there's very good data on interval training at stabilizing potentially regressing plaque. But if you're new to exercise, start slow and work your way up. Not quite sure how to answer this question because I don't know exactly what the endpoint is, but the question was, how do cells lose their ability to take up oxygen efficiently, aside from bad diet and no exercise? The cells don't really lose their ability to pick up oxygen. The only way that they would do that is if you were hypoxic, because you're at altitude, you're getting carbon monoxide poisoning, we got horrendous CPAP issue, I should say sleep apnea, and you're stop breathing and you're becoming hypoxic because of that. But if you mean more about why do the mitochondria not efficiently use oxygen, there's many reasons, but it's loss of redox potential. You lose the net negative charge inside the mitochondria. You can improve the net negative charge by optimal sun exposure, optimal sleep, so that your body does the appropriate mitophagy and mitosis at night, or mitophagy and apoptosis at night. And then exercise can potentially improve it because you're increasing the flow of blood to the cells. You're breathing heavier, breathing in more oxygen, bring it to the tissues. So those are some of the ways you can potentially improve it. Then the question, ideally, where would you want ApoB? I have FH, which stands for familial hyperlipidemia, and they're doing their best with their diet. Thanks. So ApoB is the wrapper of the lipoproteins. So in my office, I use a tennis ball analogy. So the tennis ball is the LDL particle. The white stripe on the tennis ball is the ApoB protein that holds the thing together in a sphere, and ApoB acts like a little key to bind to different receptors. When you have familial hyperlipidemia, it's often an issue with either how your body produces ApoB, the LDL receptors are dysfunctional, or you lack PCSK9 ability to basically keep your LDL receptors out. So you have a gain of function, PCSK9, I should say. So familial hyperlipidemia generally is not going to respond to dietary intervention significantly. So most of the time you're just thinking about which pharmaceuticals are likely to work best for that individual. But it's also about what's going on with the lining of the arteries. If you have an unhealthy glycocalyx, which is the lining of the arteries, think of the consistency of your white of your eyes or egg white, you got to fix the glycocalyx. If your nitric oxide pathways are dysfunctional, repair the nitric oxide pathways. You can use biomarkers to look at oxidative stress and inflammation. If you have a lot of inflammation, the arteries are on fire, the high lipoprotein burden you have from FH is likely to contribute to more and more plaque formation in that instance. So look at the arteries. Do you have abnormal carotid endomedial thickness scans? Do you have an abnormal CT coronary calcium score? Do you have an abnormal CT angiogram? Then you're going to have much lower ApoB targets. But most people should have an ApoB at least less than 100, 70 if you're trying to be more aggressive, and 55 if you've already had cardiac events. But with FH, generally you're looking at either a combination of statin and ezetimibe, PCSK9 inhibitors like Repatha, Praluent, or aspirin, or if statin intolerant, potentially Nexletol. But it's not as potent as statin, so it falls down to fourth line. Not telling you the diet's not important, but it's not going to have a major effect on lipoproteins for people with FH. And this is another individual, but they say, what is the first thing you say if the LDL cholesterol is above 669, HDL is 89, and triglycerides are 151? Well, triglycerides over 151, if it's in a fasted state, that would be elevated. That potentially means you have some issues with insulin resistance. You may have issues with the way your body handles carbohydrates. You may have issues with the way your body metabolizes fats. You could do a GB Insight genetic panel to figure out if that's the reason why you have high triglycerides if you're not insulin resistant. The HDL89 is not really that significant of a marker to determine risk. High HDL, particularly when it's above 60 like that, is often a marker of dysfunctional HDL. The HDL is actually potentially more pro-atherogenic than it is beneficial. There's no such thing as good cholesterol. So just having high HDL is not necessarily cardioprotective. You'd want to test, not guess, and look at the arteries themselves. But the question really is about the LDL of 669. If that's been that person's number their entire life, then that's familial hyperlipidemia and likely homozygous familial hyperlipidemia. If the person had, quote, normal LDL cholesterol in the past, and then they switched up to a keto diet, and this is what happened, then that person may be just very sensitive to the amount of saturated fat that they're eating in their diet. But if the number's always been high, there's no amount of dietary interventions that are going to get you down from 60 to 69. So the person's potentially at higher risk of atherosclerosis. Not guaranteed, because half the people who have heart attacks have normal cholesterol. But if you have a lot of a lot of LDL particles full of this LDL cholesterol, there's just more potential building blocks for plaque. So you'd want to work with an expert that understands what they need to do to help lower your risk and how they could actually assess what's going on in your arteries. All right, so those are the pre-submitted questions. So if there's any comments, questions you want to drop, I'll stick around and answer those for the next couple of minutes. For those that are joining, welcome. So every Monday night we do these Ask Me Anythings. The question box is put in my story Monday morning. I answer them in the order that they're received. They're usually going to be about lipids or calcium scores or vascular factors, but always happy to answer the biohacking ones, the quantum biology topics as well. If people are interested in diving deeper and potentially getting a case study done themselves, my school communities can be the place where that happens. There's a free 7-day trial if people want to check it out. It's drtwyman.com/school. Typically, we have at least one AMA per month, and we're going to start doing more educational case reports. And then I'm also still very deep into learning how to utilize AI to educate better, so making different infographics on prior podcasts I've done. So if you're interested in that, check out the school community. I'm not seeing any other questions or comments tonight, so I guess we'll have it be a brief one for you guys. If you want to see the replay, it's always going to be in my Instagram archives for the next month, but oftentimes Instagram will take these down after a while. So I will scrape this, put it onto my YouTube channel, which is drtwyman.tv, and all the archives are there of my prior Instagrams for the past few years. So appreciate you guys' time and attention. I see one other question popping up, so I'll answer that, and then we'll let you go for the night. So the one question that popped up was, is atherosclerosis plaque build up in the arteries? The short answer is yes. We have an artery lining called the glycocalyx. Underneath that, the endothelium. That is kind of the protective coating to the arteries. The blood is floating in the lumen. So think of a garden hose that you slice in half. The hole is where the blood is flowing. The lining of the artery is the endothelium and endothelial glycocalyx. Underneath that is the intima. Underneath that's the media. Underneath that's the adventitia. The plaque forms in the lining of the arteries. Oftentimes the arteries positively remodel. The plaque is building up in the artery wall like an iceberg. The artery gets bigger initially, and then eventually the plaque may start encroaching on where the blood is flowing into the lumen. Sometimes that takes many years before that process happens. The person may have no symptoms before the plaque builds up, becomes inflamed, and ruptures. So that's why you have to go looking for the plaque itself. CT coronary calcium scores can see the hard calcified plaque. CT angiograms can see both the hard and the calcified plaque. And then question, somebody says, best markers to check if concerned about clots. Definitely not my area of expertise, but typically, if the person is concerned about a deep vein thrombosis, a blood clot in their legs, or a pulmonary embolism, or blood clot in their lungs, a deep vein thrombosis will be useful. A D-dimer will be useful to determine, is it likely that a clot is present. Now, if the person has hypercoagulable issues, then they may need other markers like protein C, protein S, factor V Leiden. There's a couple other ones, lupus anticoagulant. I usually refer patients to hematologists to do the hypercoagulable workup if somebody's had repeated emboli. And the question is, aspirin protective for heart attacks or strokes? The short answer is, it depends. It always depends on what is the underlying risk. If the person has already had a cardiac event, a heart attack, a stroke, they have a stent, they've had bypass, then yes, they will benefit from aspirin more than the risk of bleeding. If somebody is generally younger, if they don't have plaque, particularly if they have a calcium score of 0 and they have a normal carotid scan, their risk of bleeding on aspirin may outweigh the benefit of reducing stroke and heart attack. So you have to individualize it to the person. There are no one-size-fits-all protocols. So that's why I don't tell people they have to eat a certain diet, that they have to take every supplement of medicine. It's completely customized to be proactive and preventative to that person. So we had kind of a flood of questions at the end. Always appreciate the questions, but if you want to be sure that they get answered on these Instagrams, because I'll stick around as long as questions are coming in, is submit them ahead of time. The comment box in my questionnaire will be in my story for, generally about 7 a.m. Central Time until the 6 p.m. So you got a good 11 hours to get your questions in. All right, one last question. So lumbrokinase protective. If you have high fibrinogen, potentially, but it does not replace aspirin. There are case reports of intracranial hemorrhages with nattokinase and lumbrokinase, so you need to generally be very protective with doing harm with people with supplements. So you need to work with somebody who is monitoring, what you're trying to treat with lumbrokinase. So it may help, quote, thin the blood, but it is not as well studied as aspirin or the antiplatelet agents that are, on the market. Somebody just sent in a thank you for doing these Instagrams. So you guys are very welcome. Appreciate it. So question, do statins provide a specific benefit than others like PCSK9 inhibitors, ezetimibe? Don't. I use an antithrombotic. Statins may help support the endothelial glycocalyx. They do particularly lower inflammation measured by hsCRP. There's data that statins can regress or shrink plaques. Ezetimibe doesn't have as much data on plaque regression, but the PCSK9 inhibitors, particularly Repatha, is having good data on plaque regression by CT angiogram analysis. So they are tools to be used. There is no one-size-fits-all with them. Not everybody can tolerate statins, so fortunately you have other options to treat lipids if you need to treat lipids, but it's really about controlling the nitric oxide pathways and keeping inflammation low first. And then if you can't control your lipids, doing dietary interventions, talk about what options you might be open to. So why use ezetimibe? If you have hyperabsorption of sterols, ezetimibe is going to work better than statins in those people. Approximately 20% of the population has high cholesterol being reabsorbed in the gut. Ezetimibe blocks that reabsorption. It blocks the Niemann C1 PIC receptor. Ezetimibe is not as potent or as strong as statins and PCSK9 inhibitors, so generally it's not used often for monotherapy, except in the cases of cytosterolemia. Interestingly, I saw a case of that recently. It's a 1 in a million type of diagnosis. Ezetimibe is essentially the only medication that will work for the people that have that disorder, where they reabsorb significant amount of plain sterols and cholesterols from their gut. So ezetimibe works very well for them, but it also works for many people as add-on therapy to statins if they're not at their lipid goals. Well, again, I thank you guys for your time and attention tonight. I appreciate your questions. It's always good to be able to educate people on how they can really reduce the risk of having a heart attack or stroke. Your health is in your own hands. I always joke sometimes that, I'm the kind of like a Sherpa. Like I don't, do it for you. I just point you in the right direction and let you guys know what are the options. So this is something that I really enjoy doing. I love the teaching. So thank you for letting me continue to do that. I just say one last question, so I answer that, then I'll let you guys go. So if somebody has high lipoprotein A, what are the best antithrombotic habits, supplements, or medications? Aspirin's the best antiplatelet therapy for people with high LPA, given that they don't have high bleeding risk. And it's more looking at the biomarkers such as LPPLA2 activity, IL-6, and OXPLA-ApoB. If those are elevated, then LPA is more likely inflaming the arteries and the person's probably laying down plaque. Then use whatever type of lipid-lowering therapy the person potentially can tolerate and shoot for likely an ApoB goal under 70 and an LDL particle goal under 1,000. And the question somebody says is, and I don't know if that was a question about, maybe even about ezetimibe, is it also good for lipoprotein A? The short answer is ezetimibe does not lower lipoprotein A, but it does lower LDL particles, which is something that can be beneficial to lowering vascular risk. So there are no drugs that significantly lower LPA. The PCSK9 inhibitors can do it about 20 to 30%, but that's probably not clinically significant. The phase 3 trials for the antisense oligonucleotides are still pending. They wrapped up in March of this year. We're still waiting for their final reports. If they're a positive trial, meaning that they lower heart attack, stroke, need for procedures, then the LPA lowering drugs will have its first one released within the year. There's at least 4 other companies working on different versions of the LPA lowering drugs. So hold on for the time being. lower all the other risk factors that you can. All right, guys. Well, I hope you guys have a rest of the night that's enjoyable. Get some sleep, optimize your mitochondrial health, and I'll see you next Monday, 6 p.m. time.